that we face. So the question, the homework each of our speakers has been given is, can SDG 8 be adequately addressed by 2030? So we're kind of midway through between when the goals were published in 2015 and the 2030 aspirations that we have. So focusing on SDG 8, on decent work and economic growth, just to remind us what that is, it's about promoting sustained, inclusive and sustainable economic growth, full and productive employment and decent work for all. So I guess a quick answer to the question is, are we nearly there yet? Is, I guess, these kind of events, working with business schools and healthcare providers, educators globally, linked to SDG 4, quality education, helps to address some of these workforce challenges. But very closely, we also have issues on gender equality, SDG 5, SDG 10 on reducing inequalities in the workforce, and also building sustainable communities, SDG 11. So only yesterday we had the IMF forecasts on economic growth and its limitations given the war in Ukraine and Chinese lockdowns. We know there are maybe full employment for people who are in the workforce, but they are suffering from burnout, strikes, demotivation. We have challenges such as migration, electives, and backlogs. So how productive and how decent is the work for people already in the healthcare workforce? So we do have some good news. In the UK, 11,000 of the 71,000 vaccination volunteers during the pandemic have actually joined the NHS, so that's really good. But only on Saturday, I saw an advertisement on Twitter from Australia, from the Royal College of GPs, trying to entice British GPs to go and work there with less paperwork and a better quality of life. So clearly these challenges are very current and are not going away. So I'd like to introduce now our three experts in the order that they're going to speak. So our first speaker is Dr. Amber Stevenson, and she is Associate Professor in the Ray School of Business at Clarkson University in New York. And she has a first degree in sports science, a master's in public health, and a PhD from Indiana University of Pennsylvania. And it's interesting that last month in Harvard Business Review, she co-authored a paper about the persistent bias against women in female-dominated workplaces, such as healthcare. So Amber is going to speak on two topics today, on gender bias and on burnout. Our second speaker is Dr. David Walcott, who's currently in Jamaica, who is on the GBSH advisory board. David was a Rhodes Scholar. He's a physician. He completed a PhD in clinical medicine at Oxford University in healthcare. And for the last 4 years, or 4 years ago, he founded Novamed, where he is now managing partner. Novamed is a healthcare investment and consulting firm. So David is going to talk about emerging markets, capital flows and investment, and cross-sector business models in relation to SDGs 8 and 3. And then our third speaker, I'm very pleased to say, is Dr. Jim Campbell, who is speaking from Geneva, where he has been the director of the health workforce at the World Health Organization for over 7 years. He was educated in the UK, first started working in 1999 for WHO and has worked elsewhere in between. And last week was awarded an honorary fellowship of the Royal College of Surgeons in Ireland. So I've asked Jim to speak about the Global Health and Care Worker Compact as part of his talk. Okay, so now I'd like to stop sharing these slides, encourage you to engage in the Q&A, and over to Amber for 10 minutes. Thank you very much.
Thank you, Professor Davies. I am delighted to be here. As was noted, my name is Amber Stevenson. I'm a professor of healthcare management in lovely upstate New York. And I will say that it snowed yesterday, but today is lovely and sunny. As was noted, I am an organizational behaviorist by training, and my areas of research have really focused on the areas of healthcare workforce, as well as how women leaders experience gender bias. Now, in preparation for the conversation today, as was noted, we've been asked to really think about our own perspective on whether the UN Sustainable Goals pertaining to workforce, and particularly number 8, can be achieved by 2030. Now, as a child of the 80s, I must admit that for some reason, when I hear the year 2030, I think it's some far off futuristic date, but then I have to catch myself and realize by restating the question differently, the immediacy becomes quite real. Will we achieve inclusive, sustainable economic growth with full and productive employment and decent work for everyone within 8 years, okay, 8 years. So I think the question is really notably more complex than what meets the eye. And likewise, I would argue that the answer to that question is more textured and will be reliant on several factors, including how we can operationalize some of these constructs that we're talking about. So, for instance, I tend to agree with the International Labor Organization's concept of what they think of as decent work. For them, they explain equity, security, dignity. And in my mind, that's things like fair wages and equal opportunities, or maybe even equal opportunities for personal and professional development, security within employment. So for me, holistically speaking, this is really about equity and it's about justice. And I think another factor that's going to influence our ability to reach these goals will be how successfully are we able to take a systems approach. So for instance, I think it's really important to explicitly state that the success of these 17 different goals are actually inextricably linked to one another. We cannot and we will not achieve inclusivity in the workforce without also addressing things like gender and racial inequality, as well as the reduction of disparity, which are encompassed in numbers 5 and 10, respectively. It's also my belief that we cannot and will not achieve decent work for all without considering facets of employee wellness, which is in goal 3. So for the purpose of our conversation today, I'm really going to focus on these 2 key workforce challenges that I believe very much limit our ability to successfully realize UN goal number 8 regarding inclusive economic growth, and specifically within the healthcare space. So the first challenge that I'm going to discuss is gender equity. I should also start by saying that the existence and negative impact of both racial and gender biases have been well documented in the healthcare workforce. I see them as equivalently problematic and worthwhile of eradication, but for the purposes of today's talk, I really wanted to focus on gender bias because that's an area where I can really share my research and my expertise. The second challenge I'm going to mention is really burnout, which arguably we could spend an entire, college course talking about. So we'll start with what we know. We know that COVID-19 has, in some cases, absolutely devastated economic outcomes across the globe. The UN recent report mentioned job losses equivalent to 255 million full-time jobs. And in particular, women and underrepresented groups were disproportionately affected, per usual. But inequities for women and Black, Indigenous, and people of color in the workforce, it didn't begin with COVID. If anything, I think it's more accurate to say that an already inequitable landscape got worse. So for example, I know that I used some statistics from the World Economic Forum. They predicted it would take 267 years to close the global gender gap for economic participation. But they were very quick to caution that that number is likely to increase because of the pandemic. And ultimately, we know it's because women were much more likely to reduce their participation or completely leave the workforce due to the caregiver or parenting responsibilities. So 267 years, that is 10 generations from now, which is somewhat of a disheartening or maybe even sobering figure. But I also find that it's a bit of an interesting thing when I talk about gender inequality in the workplace. It is often perceived that when women are well represented in a workforce or in an industry, that biases and inequality just sort of magically disappear. So the common mentality is to, quote, add more women and stir to achieve gender equality. But that's not the reality. And my own research has really shown the existence of biases in multiple gender balanced, as well as even in gender dominated workforces and industries like healthcare. I know that in the global healthcare workforce, I think this is Women in Global Health, we make up 70% of the healthcare workforce. And if you're looking at just nursing, that increases very rapidly to 90%. But despite this, right, despite this notable representation of women in healthcare, we remain underrepresented in leadership roles. And I think we make up only about 25% of the healthcare leadership roles globally. So this can, I should stop myself and say, this is also consistent outside of healthcare. As a matter of fact, one of the statistics that you'll sometimes hear when talking about gender bias and gender equality is that there are more CEOs in Fortune 500 companies named John than there are total women on the list. So this phenomenon is often called the leaky pipeline, where you have a lot of women represented in the lower ranks of an institutional hierarchy, but very few represented at the top. Now, many authors, myself included, have documented that the leaky pipeline can be attributed to, a unique and a special set of barriers that are experienced by women. And although organizations have adopted policies that prohibit the more overt forms of discrimination, impediments to women's success often tend to be a little bit more subtle or even elusive. And because of the fact that they're really built into that social fabric or institutional functioning, they're invisible. And often because of this, they're really challenging to dismantle. So I think while women make up the majority of healthcare, we still make 20 to 23% less than our male counterparts in terms of salary. Women tend to receive lower performance evaluations, have less opportunity for, say, promotions. Often it is documented specifically in medicine, access to mentorship is a problem for women. Women in academic medicine receive less extramural research funding, and overall are still subject to overt forms of harassment, even though there are policies and regulations that limit. So it's incredibly important to the healthcare workforce. The presence of women in leadership has been associated with positive organizational outcomes like financial performance or even things like corporate social responsibility. And then there are also, there's some evidence to suggest that it's also associated with better patient outcomes. Now, alternatively, the women who actually experience the bias themselves are more likely to disengage from their jobs or to feel dissatisfied or to ultimately leave the role, right, to completely turn over, get out of the position. And we know in organizations that turnover is exceptionally disruptive, right? It is very expensive. So ultimately, barriers to gender equity are considered to operate at the societal, at the organizational, and at individual levels, right? So this sort of tri-level phenomenon. But because of this, I think efforts to really create gender equity will therefore also have to be at the societal, the organizational, and the individual levels. Okay, so that's gender equity, that's the one. The next grand challenge that I really want to kind of just touch upon is the issue of burnout. I don't think I'm speaking out of terms by saying that healthcare is a heart-driven industry. There are altruistic underpinnings to healthcare as it's truly purpose-driven work. However, what we're seeing is that the structure of healthcare delivery and different healthcare systems have increased the space, the distance between the individual healthcare workers and the original reason why they wanted to pursue a job in healthcare in the first place, which is typically what? To help people or to deliver high quality care, help improve access, or just ultimately to make the world a better place to live in. So like with gender equity, I think that burnout was well on our radar prior to the pandemic. Prior to COVID, the National Academy of Medicine reported that physicians were twice as likely to experience burnout than the general population. Most often, I mean, physicians are over-surveyed, right? So when you see these surveys about burnout in particular, the things that are listed as drivers are always the same things. Bureaucratization of healthcare, reduced autonomy, heightened regulatory requirements, increased pressures associated with the different varied payment structures. Perhaps it's a little bit more US and US related types of health systems. But with the pandemic, what we're seeing is increases in all of those things. We're seeing increases reported in terms of exhaustion and stress and fear, as well as depression. And there have been major departures from the healthcare workforce, which is further exacerbating the shortages, which we also knew were coming, and also contributing to a major costs annually. In the United States, as recently as last month, the American Hospital Association wrote to our Congress and urged them, please consider healthcare workforce challenges and burnout in particular, calling it a national emergency. And in my own recent work, a colleague of mine from Northeastern, we studied pandemic shifts and how healthcare workers prioritize their work. And what we saw was that more or less the individuals, these are all physicians, were looking to intend to reduce their hours. They are going to lower the amount of hours that they work. And they are also considering within the next 5 years to completely change their career. So I think ultimately, if we're thinking about this from the question of decent work and equitable growth, ultimately, for us to work towards the achievement of equitable and decent work in healthcare, we absolutely must address burnout and really rethink how we conceive of the healthcare workforce ecosystem. I think we need to reconsider structural interventions, policy adjustments that improve what it means to be a healthcare worker. You know, it's not about fixing the worker. It's about fixing the systems and the structures of the industry. We hear a lot about resiliency, but I think, is that what we're really talking about? We can get into that more later if there's time in the questions. But anyway, the structural interventions may include things like changing stipulations involved around physician residencies, or maybe increasing support for other types of healthcare workers, like physician assistants, nurse practitioners, advanced practice providers, or even reconceiving the boundaries of what a healthcare team includes. Developing alternate pathways and pipelines of recruitment. But I tend to take an optimistic perspective, which is strange because those who know me know that I might be a little cynical, but I take an optimistic perspective here because I think there are a lot of very compassionate, intelligent, and committed people working on this global problem. So I think if I had to sum it all up, in conclusion, I suspect we are not currently on track to achieve this UN goal, but we could really make some significant progress if things like gender inequity and burnout are reduced. So I will stop there and say thank you and hand it over to my colleagues.
That's great. Thank you very much for your insights, Amber. And yeah, systems level leadership, not just fixing the healthcare worker. I think that's a key message. Thank you. Okay, I'll hand over now to David for 10 minutes.
Thank you so much, Julie. I really have to echo what Amber had said in terms of how the pandemic has really accelerated inherent challenges in healthcare globally. And I think, burnout is one of the challenges that Amber mentioned that I have seen sort of resonate almost universally. We're seeing in both developed and emerging markets what looks like a microcosm of the Great Resignation, where healthcare workers are seeking alternative forms of employment and really losing that sense of connection that had drawn them to the career and in the first place. And this is the case for both clinical and non-clinical workers, which really speaks to our need to really reimagine the concept of what being in healthcare looks like, as the GBSH is doing. As we know, the pandemic has been somewhat of a catalyst that has shifted the face of industries, healthcare included, and it has created this strange dichotomy whereby on one hand, healthcare has been parachuted into the future, requiring that the healthcare workforce catches up. And in many cases, the capabilities have been left behind. Health tech has boomed. AI algorithms can read chest X-rays. Genomic screening can guide personalized cancer treatments. And these increased capabilities creates a paradox for the vast majority where healthcare needs remain unmet. And an evolution of the healthcare workforce is needed to bridge this gap and sort of balance the evolving capabilities and demands. As Amber had said, healthcare has altruistic undertones, and the root of healthcare is really found in its workforce. And one of the reasons why healthcare has lagged behind on the innovation curve is that its complexity serves as a barrier to innovation, and changing the structure and the function of this workforce takes time. As we understand, the crisis is far from over, but healthcare workers must serve the healthcare demands driven by the pandemic, as well as evolve to meet the healthcare needs of the future. And so, of course, if you superimpose this on the economic fallout we're seeing in COVID-19, it places a tremendous amount of pressure on the healthcare worker. Healthcare workforce stakeholders have an increasingly complex set of variables to consider. For example, pharmaceutical companies racing to develop vaccines must also navigate complex supply chains, new models for consumer engagement, and increasing levels of vaccine hesitancy, which we've seen. And so there is a multi-dimensional basket of capabilities that is required to be served by the healthcare workforce, for which, quite frankly, we're not adequately trained. And so if we look towards the horizon, we can see a set of trends that will continue to shape the healthcare workforce, and of course plan accordingly. And how I sort of visualize these changes are changes in the tools for healthcare delivery, changes in the consumer market and consumer behavior, and of course changes in the business models and economics, right? We are in for a significantly more challenging time in the days to come. Surveys have shown that C-level execs of healthcare companies believe COVID-19 has fundamentally and permanently changed their business, and the majority expect the coming years to be the most challenging in their careers. And so, of course, it's incumbent upon us to realize the forces that will shape the collective industry in the days to come and sort of plan our workforce accordingly. As Julie had said earlier, there are palpable changes in consumer behavior and the consumer market, not least of which includes the volume as we face an aging society, as the disease profile of emerging markets takes the face of the profiles of advanced economies, and of course, consumer-driven care, which actually has a much larger impact than expected. Healthcare workers, both on the clinical levels, on the administrative levels, and from the leadership perspectives, are expected to understand how to analyze, respond to, and service the needs of healthcare consumers. And of course, as we extrapolate these changes that are taking place in advanced markets into emerging markets, as there is an increasing level of consumerization that we expect in emerging markets, the levels of healthcare demand per person are expected to increase. And so if you superimpose that on the economic challenges that are faced in many such markets, where the public sector is unable to fund this increased healthcare demand and the private sector's capacity is limited, it creates a difficult situation for an evolving healthcare workforce that is increasingly stretched to service greater needs and expected to do more for less. And of course, this is something that we need to consider as we seek to mitigate physician burnout. The changes in the business models we're seeing alter the economics of care delivery. We're seeing what looks like a rise of the healthcare platform, somewhat of a bazarization of healthcare, where, while hospitals and healthcare systems still rely on traditional business models, an increasing number of open market approaches, exchanges, and platforms are beginning to reshape healthcare delivery. And I suppose, incidentally, we're seeing these trends materialize as quickly in emerging markets as they do in advanced markets, which reflects somewhat of a leapfrogging phenomenon. Exchanges and platforms have already sort of proven their worth in other industries, retail, travel, media, etc. And the responsibility of the healthcare workforce is to evolve to be able to meet this evolved dynamic of care delivery while navigating industry-specific challenges, including high regulation, complex billing processes, etc. And so, from an investment perspective, one has to understand that while we seek to create these tools to improve the quality of care delivery, we need to also create tools to evolve the drive evolution of the workforce that is inextricably linked to the delivery of care. And so ultimately the responsibility rests on all stakeholders of the healthcare delivery process, clinical stakeholders, administrative, leadership, and of course academics such as the GBSH, to really drive a level of workforce development that is applicable to both emerging and advanced markets. There is a need for technological upskilling. In other words, being able to use the tools that we now have at our disposal to optimize care. And of course, these tools in many environments represent a leapfrogging opportunity. Training our healthcare workers to be able to use simple tools like telemedicine, which of course increases access to care and lowers costs, but also more complex tools involving artificial intelligence, machine learning, etc., to improve diagnostics and boost our ability to deliver high quality care at scale. And of course, high quality care at scale is really the definition of the SDG targets that we're pursuing. Two, there has to be a level of system-based upskilling in which we develop systems in tandem with our workforce that allow us to make more intelligent decisions. And this is really a function of leveraging complex and creative problem solving, enabling healthcare workers to be competent in understanding emerging market job trends, understanding how capital should be allocated, understanding competitor benchmarking, etc. And this is the only way we sort of can define what the healthcare workforce of the future really should look like.
I think we're getting some interference here. If someone could mute. Go ahead, David.
Perfect. Someone is excited about the opportunities. And of course, to sort of having understood the need for a system-based upskilling and a need for a technological upskilling, there's a sort of future-proof upskilling movement that is required to be adopted by the healthcare workforce, where soft skills like time management, decision-making, your ability to communicate will become increasingly valuable. As we seek to use more of these technological tools, there is a risk of dehumanizing healthcare. And so a part of our upskilling mandate will be to emphasize the need for the healthcare workforce to retain its core sense of humanity. And so in concluding, the healthcare needs of the workforce in the decade to come are numerous and complex. We face an aging population, we face evolving disease burdens, and we face an evolving suite of tools for healthcare delivery. And that really drives the need for organizations like the GBSH to fulfill the increasing gap in providing a suite of skills to help the healthcare workers of the future to meet the demands in the days to come. Thank you very much. Back to you, Julie.
Thank you very much. So I took some notes on leapfrogging, parachuting, and humanizing. There's some of my takeaways there. Thank you very much for your insights, David. Okay, so we go from Jamaica now to Geneva. Over to Jim.
So good afternoon, good evening, wherever you're joining from. Well, thank you, Amber and David, for those remarks, and I may touch upon a few of them in some of the comments. If we go back to SDG 8, what we're looking at here in terms of the language is the sustainable economic growth. We're looking at decent work for all and full productive employment. And if we start to look then beyond the language of the goal, if we start to look at the targets, we see some of those elements coming through. Making sure that we really promote labor rights, making sure that men, women and youth have these opportunity for decent work and careers coming through. Making sure that we really stress the importance of equal pay for equal work of equal value. to talk to some of the equity and the pay equity issues that we have to come forward. And so if we start to look at some of those issues in the health and care economy, what does that relate to? Around the world, there are more than 230 million people working in sector Q, the international classification of this employment sector, health and care. More than 234 million. We see that almost 70%, just above 2/3, 67% of the employees are women, compared to an average in all other economic sectors of just over 41%. So we are clearly a sector that employs more women than most. And so when we come back to the SDG 8 principles and the SDG 5 principles around gender equality, it's a good litmus test to start to question, well, are we ensuring decent work? Are we ensuring equal pay for equal work of equal value? So what might that look at when we start to look in a little bit more depth and other opportunity? Because we've also got to compare and contrast to other sectors. Health and care is one of the sectors where we have a huge percentage of tertiary educated employees. It's not like the agriculture or industry or engineering. So we're as a byproduct of that education, of that investment in human capital, a lot of those jobs are actually in terms of occupational health and safety, in terms of the protections that are available for the work environment, are actually very decent compared to others. So even with the issues of the burnout resulting from the last 2.5 years, where we're seeing levels of anxiety and stress in infections, deaths, mental health illness coming to the fore, where we have identified in the last 2 years labor tensions, labor protests, labor strikes in the health and care sector in more than 3/4 of the countries in the world. 149 countries and counting in the last 2 years have had a labor dispute or protest about the working conditions. But this is, this once in a century pandemic that is fueling that and demonstrating that we've still got more work to do to make improvements on some of this issue. We identified back in 2016 when we adopted the global strategy on human resources for health, Workforce 2030, which was in line with the SDG targets. We actually identified then that we would see huge changes in the employment in our health and care economy over the next 15 years in this SDG window. And we looked at the connections between education, health, gender, and SDG 8 on decent work, and formed what was at that time the UN Secretary General's High-Level Commission on Health, Employment, and Economic Growth. And we estimated that there would be even greater increases in the number of jobs in this industry because of economic demand, responding to population needs, to aging populations, NCDs, and the commercialization of healthcare and the commercialization of health education. And as that economic demand and that political demand continues to generate that, so we would see more and more jobs coming into the industry. The same is not true, however, where that economic demand is very fragile in low and middle income countries. And we were particularly concerned that low middle income countries may fall further and further behind. It was what you were talking, Julie, as well, about issues of migration and everything else. To especially if pay, we talk about decent work and decent pay. If pay doesn't keep up with inflation, it's a substantive push factor in the migration challenge. We're seeing then the COVID pandemic, the Ebola the Ebola virus, the Zika virus. We've been living with viruses since the SDGs started. Having this impact on this economic market considerations to come forward, and job growth is growing exponentially. And there's, at the same time, there's not enough global supply in the system to meet that demand, because for far too long, high-income countries have kept their production supply, education supply, artificially low. They've not ensured that we're oversupplying the labor market, because they know they could get graduates from all over the world to come and work in their healthcare systems. We're now paying for that decision not to oversupply in terms of our industry. So we're going to have, therefore, some major challenges on the decent work agenda as a result of this global economy, the downturn in the global economy, where social spending on education, health, and social protection, government expenditures in these areas are going to be stagnating, if not regressing, in the next few years. The IMF and the World Bank saying the same. And so inevitably, what the governments do, what the political parties do, reduce the decent work conditions for the employees. They reduce pay. They don't keep up with inflation. They take cuts in terms of growing the workforce for safe staffing levels. They reduce the career development education opportunities, the lifelong learning commitments, because employees are often seen as a very quick solution to cut cost. But actually, therefore, by cutting costs, we're actually taking us further and further away from SDG 8, from SDG 5, from SDG 3, by doing so. So the issue then is about how we make sure. So that's the big picture. I'm particularly wanting to come back to some of the issues raised around the burnout and the issues. We have seen the mental health illness amongst the workforce, the health and care workforce, grow exponentially. We are living systematic reviews and other publications looking at this, continuously updating our evidence and knowledge on this and the recommendations of what actions need to be taken. One of those actions is to produce a global health and care worker compact, which the member states of the World Health Assembly invited us to do last year. And this is a global public good. What it does is it consolidates all the evidence that we're aware of around employers' obligations, whether that employer is in the private service, the public service, the government, to ensure the occupational health and safety, the gendered dimensions, the prevention of attacks on healthcare and health facilities and health workers, the opportunity for collective bargaining and association. And it brings all of those together into a single reference source, which is available now on the WHO World Health Assembly website. It will be reviewed by member states next month, to considered and discussed in the Assembly, and welcomed or noted as a technical document for what it is. Really, we're calling upon all employers, all associations, all unions to use this as a tool to benchmark where are they in any given context. And once they know where they are in comparison to, states' obligations, in comparison to international labor law, what needs to be done to improve this environment, not to necessarily demand all those improvements, but actually lay out, this decent work agenda, these labor rights that are part of SDG 8 have to be really delivered and developed in our sector. And finally, we will publish in the next meeting of the high-level meeting on gender equality, which is scheduled for June. We will publish an update, WHO and ILO, of the gender pay gap in the health and care economy, and the reasons and the rationale for that, updating the paper we did in 2019 and looking at it. And without giving too much away, there will be a need to update many of the numbers that we hear regularly cited with this new thing. But the good news is we seem to be going in the right direction. There has been progress. So we, obviously progress not on a linear curve, but there has been progress and we need to take that forward. Julie, back to you.
Well, that's great. That's very reassuring that the Assembly is addressing these issues. And with the benchmarks, will there be like rankings or employer branding? Do you think people will use these to try and attract the best, perhaps?
One of the values of the decisions made by ministers and the World Health Assembly is that it creates an opportunity for civil society, for researchers to do exactly that and start to look at, okay, well, might we use this as a tool to, set standards, to benchmark at a country level. I think where you need to take those type of benchmarks have to be conversations at a national level. It's rather than an international level, because it's within a country that it is where it matters.
That's great. Thank you very much. Excellent. Okay, so I have a question here from SK Nayak. So Dr. Campbell, you see the question, Jim. Is the Health Workforce Support and Safeguards List 2020 published last year now being adopted and accepted by the World Health Assembly? Is it now okay to use it for physicians' nurse migration purposes?
Indeed. So it was requested by the World Health Assembly to publish that document. So as soon as it was published, it became an official document. It is influencing codes of practice around the world. For instance, Julie, the UK, the English NHS and Scotland both have updated their code of practice to ensure that the Health Workforce Support and Safeguards List is recognized. Germany is another country where they have legislation. So it is being used. There is a report to the Assembly on the Global Code of Conduct, Code of Practice on international recruitment of health personnel, giving an update on the situation, and there will be a revision to the Health Workforce Support and Safeguards List published before January of 2023.
That's very helpful. Are you finding it small countries like Estonia seem to be showing us the way, or are there particular pockets of excellence in terms of?
What we're saying is that, and this is true of the COVID-19 pandemic is fueling greater economic demand. We saw Italy recruit 14,000 health workers in a matter of weeks. We saw the UK with its vaccination team campaign, 70,000 additional people into the vaccination teams, the US, OECD countries everywhere. That is fueling, though, at the same time, individual choice. Like I said, with our health and care economy, we have tertiary educated people from, who have with accredited professional licenses, accredited degrees, professional licenses, who have therefore an international currency. They have an international value, and they are choosing to make their personal decisions. Many times it's not that they're necessarily being, no one forces people to use your human capital to your advantage. It's always been there. But we do need, with these support and safeguard principles, That it is starting to get very concerning, that the push and pull factors now have become, with COVID-19, have become too great for some countries to be able to respond to, in terms of an economic response, because migration is too powerful a pull at the moment.
Yeah, so as David said, people are leaving administrators, clinicians, non-clinicians, as much as you are making progress with the lists and other mechanisms. The Great Resignation is happening as well as the Great Migration.
I'm a little bit careful. I think we're seeing, again, employment figures on this from different jurisdictions. We're tracking these and coming forward. There is a high turnover. There's a high turnover, but you would expect to see that. That's because more and more people are making personal decisions about quality of lifestyle.
Life. Yeah.
And this Great Resignation is actually maybe renegotiation of their contract hours, or a renegotiation within moving from one health authority to another health jurisdiction in the same country. So they may be leaving, but they're also joining somewhere else for a slightly different balance of work life.
It's a bit of a mix.
So it isn't just a Great Resignation that's happening. There are many other employment labor phenomena occurring in parallel.
Yeah, I think as Amber started off, it's very nuanced and textured. Great, thank you. Another question from the same person. Is it possible, please, to know the methodology being followed for the 2023 list? And they have their email there if you want to contact them.
Exactly. So it's on the WHO website. The relevance and effectiveness review of the code of practice, the methodology is published there. We can follow up with the link afterwards. And the review group will look again at the additional factor this time will be looking at the vulnerabilities resulting from the COVID-19 pandemic, because these are some of the issues which we know. Member countries are reporting backlog healthcare services, disruption to essential health services, challenges to get the vaccinations shots in arms. These are vulnerabilities which may not be in their official data from last year, but they're experiencing today. So we're as a unique requirement of the COVID-19 pandemic, we'll be looking at some of those vulnerabilities.
Okay, thank you. I have a question for Amber. Can you provide some positive examples where organizations have managed burnout successfully or prevented burnout?
You know what? Yeah, that's an excellent question. And I think that it's good to remind ourselves that there are positive things that are showing promise in terms of how it's being impacted, right? So we have to think about this at the level of organization, at the level of culture. And culture change is really going to be essential, and particularly around medicine and healthcare, because if you think about the industry, it's keep doing what you're told, don't complain, work harder, don't stop, you're going to push through it. And it's always the caring for others, not necessarily taking on care for the self. So I think, inherently what we're starting to see and I think to Jim's point and to David's point, COVID ushered in some of these changes. We have seen a recent emergence in a new title of something called the Chief Wellness Officer. And I know that has had mixed perspective in terms of its effectiveness thus far. But I will say that the focus from an organizational perspective of the Chief Wellness Officer is really to address these matters that seem to be creating the environment that is fueling the feelings of burnout. If you think about burnout from a definitional perspective, you're really talking about exhaustion and depersonalization, and feeling like you're no longer able to do the work that you once did at the level you once did it, right? That lack of achievement feeling. So I think that by creating putting together structural things like a new chief level, leadership level position that is meant to be mindful and always focused on this particular factor is a very small step in the right direction. And I think that is inherently encouraging. I'd also argue that there's little things, right? Because this is like gender bias and gender equity. burnout, it's not going to be a magic bullet answer. You're going to see a variety of complementary practices that happen across levels that ultimately help to chip away at the problem. And I think that's little things like shortened shifts, improving processes, right? So for, in the United States, with the literature, you'll find around the concept of the EHR systems, it's not their friend, right? So there's been a lot of negativity around that. So improvement of processes that try to help that clinical workflow. Other things are, I would even argue, more at the micro level. My area is org behavior and leadership. Empathetic supervision, compassionate supervision, having someone above you who expresses openly that feeling of care just makes people feel like they're heard and makes people feel like they are respected within the role that they're. It doesn't solve burnout, but it helps with things like that. So I think those are just really literally a couple of examples. There are obviously others, but I think that those are a few that, and hopefully we'll see more, right? Hopefully with everybody working on this problem, because everyone's paying attention to it, hopefully we'll see more things that obviously will yield that positive outcome.
That's interesting. So chief wellness officers in the C-suite, interesting. I did a study of just a rural hospital, a general hospital A&E department, and it was those little triggers, the newly qualified nurses, like 3 in the morning on a Saturday night when they were on their own and someone died and they wish they'd been with that patient. And it's like, if they'd had that empathetic ear at that point, someone said, just go home, or you will have that point at 3 o'clock in the morning, early in your career. But that isolation that David was talking about, dehumanizing healthcare, is a real issue. Thank you. Okay, so Amber Qureshi, who's I know is a dentist and a coach, said a great discussion. As per David and Amber's comments, rehumanization and burnout respectively, do you think national curricula in our international curricula at undergraduate and postgraduate level could help rehumanize and avoid burnout? So David, any thoughts what you might have had in your curriculum as a physician that might have somehow?
I have very strong thoughts. Thanks, Julia. I have very strong thoughts about the need to provide an educational experience that is sort of balanced in multiple directions. I think it's very easy to be allured by the technological appeal of healthcare and sort of engaging in an exercise of learning about how to navigate the evolving healthcare landscape from a technological perspective, learning genome sequencing, AI, etc. However, that is just the tip of the iceberg. The grand iceberg is the sort of everyday bread and butter, healthcare provider-patient interaction, and I think it's easy for those things to be left behind as we focus more on the boundaries of our technological capabilities. And so I think it's incumbent upon us as custodians of the educational experience to add a holistic perspective to our workforce. And again, this is our clinical workforce, or administrative workforce, and beyond, and sensitize the workforce to not only the need for considering work-life balance, considering wellness in their professional experiences, but also the need for preserving the spirit of healthcare, which is ultimately a humanizing service. It's the way we engage with the Hippocratic Oath in today's world is very different from how we did when it was founded, let's say, and the pressures that sort of take away from our ability to connect. Like, our world is becoming a much less connected space. As Jim mentioned, there's a reason why mental health is increasingly under attack, and this exists for healthcare workers as well. And so I think it's important for us to overinvest in retaining the level of connection and humanization that really defines what healthcare is.
Yeah, so thank you very much. So I guess those socio-technical systems, yeah, we've been alienated and isolated in the pandemic, and bringing back community. And I think there was one medical school in the UK down the south that they bring the patient day one for students to talk to patients, and they do drama and they write poetry and they paint, like the painting behind Jim. You want to comment? Go ahead.
Yeah, just on Amber's question as well. Earlier this month, we published during World Health Worker Week, just a few days, first week of April, aligned with World Health. We published a global competency and outcomes framework, which was a result of 4 years of work with several hundred education experts from all over the world. We looked at over 300 different competency frameworks that we could identify, not just in the health and care sector, but across different occupations and licenses. And this issue is very much about looking at how the competency to look after yourself, the competency to protect yourself, and the professionalism of the role. You know, there's a lot of work happening on medical professionalism around the world about the different professional roles, but it's in there. So I'll paste the link in there. What we hope is that that framework starts to inform undergraduate, postgraduate curricula all over the world. It's another global public good to try and get people to think through that, and how does that translate into practice to bring curricula up to standard.
That's really helpful. So lots of documents in the WHO that we can look at that have been published and are going to be published.
If you don't mind, I just wanted to add one last very short thing. I agree absolutely with both of my colleagues who mentioned, but I do want to point out that I also think what we're seeing in respect to this is a destigmatization around the concepts. So ultimately, in conjunction with the different creative things that are being done within the curricular space and the educational and the learning environments, I do think that culturally, societally, the notion of burnout is no longer as much of a stigma or a faux pas or something to be embarrassed by. And I think we have to keep chipping away there, because I think we can make great progress there as well. That's all. Thank you. That's
great. I think it's a very important point to end on. So thank you. It is 6 o'clock. We have to be mindful of our well-being and have a break from screens. So that was a fascinating conversation of excellent discussions. Thank you, the audience, for your questions, the panel members for your excellent insights, and that will be available, that recording, very soon. So thank you all very much. We look forward to future events and working with you. So thank you.
Thank you. Have a good day.
And you.
Thank you.
Take care. Bye now.